I'm going to introduce our next speaker, Dr. Jorge Cortes, who's joined Augusta University as Director of Georgia Cancer Center in Augusta, Georgia, after being at the University of Texas MD Anderson Cancer Center for 27 years, where he had many roles in Department of Leukemia Division of Cancer Medicine. Dr. Cortes has authored more than 1,000 peer-reviewed original research articles. Welcome, Dr. Jorge. I think he's going to present through the video, and then he will be with us to answer the question.
Hello, my name is Jorge Cortes from the Georgia Cancer Center. I'm going to talk today about combination therapy for chronic myeloid leukemia. And of course, we know that the outcome of patients with chronic myeloid leukemia has increased very significantly with the use of tyrosine kinase inhibitors. Here on this slide, you can see on the left the improvement in survival at the MD Anderson Cancer Center. And then on the right, the epidemiologic data in the US. And you can see that both of them reflect a significant improvement from the 1970s when the Philadelphia chromosome was discovered to the current decade. And mostly representing in the last curve, in the most recent curve, the introduction of tyrosine kinase inhibitors. Now, it is very clear that the improvement is not the same in the epidemiologic general data from the whole of the United States. Still, we know that this improvement has come from the introduction initially from imatinib, which already gave us outstanding results, with the majority of patients achieving a complete cytogenetic response and even a major molecular response. And then with the introduction of the second generation tyrosine kinase inhibitors, dasatinib, nilotinib, and bosutinib, all these three demonstrating in randomized trials a higher rate of responses, deeper responses, earlier responses, a decrease in the rate of transformation to accelerated phase and blast phase. However, we do know that they do not improve the progression-free survival or the overall survival compared to imatinib. Now, I showed you earlier that the improvement in survival is not the same for the overall population in the United States as it is in the MD Anderson Cancer Center or in selected institutions. Why is it that we do not have all that improvement in all these places? Well, this is somewhat beyond the purpose of our presentation, and it has to do with the access to drugs, the adequate management of the patients, the monitoring, the adherence to treatment, and many other factors. But we also need to recognize that even in the best case scenario, in the clinical trials, the randomized trials that led to the approval of the second generation TKIs, you can see that by 5 years, about 40% of patients, whether they're receiving a second generation TKI or they're receiving imatinib, have discontinued therapy. So evidently, a significant number of patients are not getting the outcome that we want, either because of efficacy or because of safety. And we have the 10-year data for the NSTND trial, and this has risen up to 50% of patients. So half of the patients do not get what we want to achieve with a single agent tyrosine kinase inhibitors. In addition, one of the goals that we have now for patients with tyrosine kinase inhibitors is treatment-free remission. But if we look, the rate of the achievement of deep molecular response occurs in about 50% of the patients, sustained deep molecular response by 10 years. That is the data on the left from the NSTND. So half of the patients get to that goal, which we need for treatment discontinuation. And then when they discontinue, about half of the patients are able to maintain the treatment-free remission. So that means that about 25% of patients can successfully discontinue therapy. So again, it is a great achievement, but it is only a minority of patients who can get there. And we know that this is because the tyrosine kinase inhibitors cannot eradicate the leukemic stem cell. This is data that goes back several years, initially from Tessa Holyoka, and many others since then, showing that these early stem cells are quiescent and therefore insensitive to the effect of the tyrosine kinase inhibitors. So if we look at it in a different way, the bulk of the cellular population, the cells that are proliferating, are very sensitive to the tyrosine kinase inhibitors. But the earlier progenitors are not sensitive because they are quiescent, they are not replicating. So with all of these background, what are the potential uses of combination therapy in chronic myeloid leukemia? Well, we could decrease the failure rate because some patients in the front line and even more in the second and third and fourth line of therapy experience failure to therapy. We also could improve the rate of deep molecular responses. I showed you that the sustained rate is only 50%. We also want to discontinue the relapse rate after discontinuation, another 50%. Ultimately, what we want is to eradicate the disease so patients don't transform to the advanced phases, so that everybody could discontinue therapy, etc. And talking about advanced phases, the outcome there is clearly not as good as we have in the chronic phase. And more recently, we're learning of the molecular complexity of CML, where even at the time of diagnosis, many patients, up to 25% of patients, may have additional molecular abnormalities in other cancer-related genes, such as ASXL and RUNX1, etc. So what other targets can we approach in chronic myeloid leukemia for use in combination therapy? And this is a cartoon of some recent manuscript that's a very good overview by Ravi Bhatia, looking at the different targets that communicate with BCR-ABL and that lead to the proliferation of the cell, the survival of the early progenitors. Some of them have made it to the clinical trials, and we know that these different targets may lead to resistance and the persistence of that leukemic stem cell. Let's look at some of the data in vitro. This is with interferon, perhaps one of the drugs that we know the best because we've used it so much in chronic myeloid leukemia. And there is some in vitro data suggesting that the use of interferon may bring those leukemic stem cells from that quiescent state into a cycling state, which then makes them sensitive to the use of tyrosine kinase inhibitors. That is the concept behind some combination studies of tyrosine kinase inhibitors with interferons, such as this one from Germany called the TIGER study, where newly diagnosed patients are randomized to receive either nilotinib alone or nilotinib plus pegylated interferon. Curiously, after 24 months of MMR, the single agent arm continues nilotinib, the combination arm discontinues nilotinib and continues with interferon, and then ultimately leads to discontinuation of all therapy. But when you look at the results, you can see that although with the combination, you can get a slightly faster response in MMR and MR4 and MR4.5, ultimately you get to the exact same point. So it really doesn't improve our ability to get to these deeper molecular responses. There is another study, this one coming from Australia, also for newly diagnosed patients with chronic myeloid leukemia. This is a single arm study, phase 2. Everybody gets nilotinib at the beginning. After 3 months, patients get added a pegylated interferon 2A. And you can see here that the MR4.5 rate looks very good. At 12 months is almost 34%. And by 24 months, it reaches 50%, whereas the MMR rate is 78% at 12 months. This looks very good, but when you put it in the context of what we know with single agent nilotinib from other studies, from the randomized studies or the MD Anderson study or the GMEMA study, these rates of the deeper molecular responses at 24 months, the MR 4.5, they do not look that much different than what we can achieve with single agent dasatinib or nilotinib at the MD Anderson. So really, it doesn't look like the combination has achieved much. Now, we need to see if in the long term, it will decrease the rate of relapse after treatment discontinuation. That data is not yet available. In trying to improve the rate of the deep molecular responses, one of the options that has been investigated is to switch patients who are on imatinib and switch them to nilotinib. And in this randomized study called the NS-CMR, that was the endpoint, that was the goal. And it was clear that the rate of CMR at 24 months increased with the switch to nilotinib compared to continuation with imatinib. But that came at a cost with a higher rate of adverse events, particularly arterio-occlusive events, which was 6-fold higher for the patients who received nilotinib instead of imatinib. So an alternative approach is that for those patients who are doing well on imatinib, but not quite with the deep molecular response, add a combination at that point with another drug. And this is just a partial list of some of the studies that are currently ongoing. Well, let me show you a little bit of data. This is one study that we did at the MD Anderson, adding ruxolitinib. And as you can see, there was really very little benefit that we could see on these patients. Most of these patients remained with the same levels of transcripts after the addition of ruxolitinib. And this was based on the dependence of JAK2 for these leukemic stem cells. We did another study where we added azacitidine, and this one looked a little bit more promising. We had 3 patients, and all of them had a significant decline in the transcripts. However, azacitidine is a complex administration, intravenous or subcutaneous, and patients were not very keen on receiving that. Whether that will change with the oral availability now of hypermethylating agents, it may be a more practical approach that perhaps is worth considering. Venetoclax is a very interesting drug because these earlier progenitors are also very dependent on BCL2, and there is in vitro data that I'm showing you here that the combination of in this case, nilotinib with a BCL2 inhibitor similar to Venetoclax leads to increased apoptosis of these earlier progenitors, particularly important, even those that are quiescent. So combinations with Venetoclax and the tyrosine kinase inhibitor are currently being explored, but we don't have really data at this moment. Of course, we'll have to see what happens with the increased myelosuppression or other adverse events. Assymine is a very interesting drug. It's a tyrosine kinase inhibitor, but it binds to a very different area. It's what we call a STAMP inhibitor. It's a first-in-class, specifically targeting the able myristoyl pocket, which is distant from the ATP binding pocket where all of the other inhibitors bind. And we have seen remarkable data of this drug in patients who have experienced failure to 2 or 3 pyroterosine kinase inhibitors, confirmed on a randomized trial recently shown at ASH, and also very effective against T359. But importantly for this discussion is the fact that animal studies have shown that when you combine the two drugs, a traditional tyrosine kinase inhibitors, in this case nilotinib, with asciminib or ABL001, you completely prevent the emergence of resistant clones in this xenograft study. So there have been attempts at combining these 2 drugs. There has been, this is the original phase 1 study that included combination arms, and there was a combination with imatinib. This was for patients refractory or relapsed to prior therapies, and it showed the good probability of response. You see here almost 60% complete cytogenetic response, and MMR by 1 year of about 42%. There were also arms in combination with nilotinib and with dasatinib, and these also led to very good responses. Again, these are patients refractory or relapsed prior therapy. With nilotinib, you see complete cytogenetic response in 2/3 of the patients, MMR in about 1/3 of the patients, and with dasatinib, the same thing, an MMR rate of 36%. But more important is that these combinations are being tested to deepen the molecular response. So there has been a study for patients who have been receiving imatinib and have a good response, but not quite the deepest molecular response. And they are then randomized to either continue on imatinib, switch to nilotinib, or to add asciminib to the imatinib. And a similar concept that we started at the MD Anderson for patients on dasatinib, nilotinib, or bosutinib, and exploring the combination, adding asciminib, again, patients who are doing well, complete cytogenetic response, but not deep molecular response, to see if that can help, number one, achieve a deep molecular response, and number two, decrease the rate of relapse after treatment discontinuation. Let me switch gears to a place where the combinations are much better established, and that is for the blast phase. We know that the outcome for patients on blast phase is very poor. Even for in the era of the tyrosine kinase inhibitors, the outcome is very poor. Some responses, but these are not durable. And in the end, the overall response and overall survival is very short. However, as you can see on these curves on the right, the survival is better for patients who receive TKI plus chemotherapy. And this is any TKI with any chemotherapy. This is just a general. But the combination improves the survival, the failure-free survival, and the response rate compared to the use of a TKI alone or a chemotherapy alone arm. So the combinations are suggestive of providing benefit in this context. We have explored a number of different combinations. This was the first one we attempted. This is many years ago. And we used low-dose cytarabine in combination with either rubicin and imatinib. Small study, only 19 patients, but we did get some good responses. The advantage of this regimen is that it is very well tolerated. Now, because this is an old study, we used imatinib, it is likely that combining low-dose cytarabine with a more potent tyrosine kinase inhibitor, a second or perhaps better, a third generation TKI such as ponatinib would give us better results. We also tried something similar with homohorintinin or romacetaxine. This regimen can be more myelosuppressive, but you can see here that you can achieve good responses in some patients. Again, this is a small study, but it does suggest the benefit of this potential combination. More recently, we just published a study combining a hypermethylating agent, in this case, decitabine, with dasatinib. This had a phase 1 component and then an expansion component, and it included patients in the blast phase, accelerated phase, or Philadelphia positive AML. And if you can look at the bottom here, you can see that there was a good response rate with overall 19 of the 27 patients achieving some hematologic response. Half of them was actually a complete hematologic response, which is very welcome. But not only that, we did get some patients achieving complete cytogenetic response. You see here, 12 patients achieved a major cytogenetic response, and even 9 patients achieved an MMR or an MR 4.5. So a combination that could be beneficial. And you see here the hematologic response duration, the overall survival. Now, we do want to transplant these patients, and that was the preferred outcome after they achieved a response. But achieving high levels of response with a regimen with very low toxicity is certainly very welcome for that principle. Our colleagues from the Hammersmith did a different approach. They used a combination of a more intensive regimen, FLAG-IDA, with ponatinib, and you can see the schema here. I'm not going to go into much of the details, very standard regimens, but they reported a high response rate of 69%, and you can see here the overall survival of 47%. Notice there is not much of a plateau. Not everybody received a transplant. About half of the patients did, and certainly that is what you want to do in this context. In lymphoid disease, we have combined TKIs with hyperCVAD. We published this a few years ago. You can see there seems to be a better outcome in lymphoid diseases. 90% of patients achieved a complete hematologic response. However, the responses tend not to be very durable. They're better, of course, if you do a transplant, and they are better if you combine it with dasatinib. And recently, there was an update of this publication, of this approach, combining hypercivat specifically with dasatinib. And you can see here, both for Philadelphia positive ALL and lymphoid blast phase, you get better than you would get with single agent, although still this needs to be improved. And the outcome is better if the patients achieve MRD negativity after the regimen. So in summary, there is some in vitro synergy of tyrosine kinase inhibitors with many drugs, some even chemotherapy, but more attractively, some of the targeted agents. How we're going to choose them remains to be seen. Some of the early studies, particularly with interferon, where we have more data, they have been, in my opinion, somewhat disappointing. We'll have to see if it helps for the duration of treatment discontinuation, which is perhaps where the benefit may be mostly seen in the chronic phase. In the blast phase, certainly combination is the way to go, but the combinations that we've explored to date have still much improvement to be made. So to conclude, I'm going to finish with this phrase from Karl Poppers that said, our knowledge can only be finite, while our ignorance must be necessarily infinite. Our ignorance in this area is still very, very large. So these are my disclosures. And with this, I conclude, and I thank you for your attention.